Welcome to the deep dive. Today we're diving straight into hyperlipidemia, really focusing on the pharmacologic strategies you need for managing high cholesterol, drawing from that core pharmacotherapeutics material.
Yeah, our goal here is to distill the essentials for treating hyperlipidemia or dyslipidemia. They're often used the same way, and it's a huge issue. Sources point out, historically, over 100 million adults in the U.S. had cholesterol over 200.
Wow, that's a staggering number. And it really highlights why this is so important clinically. We're not just talking numbers on a lab report. This is about tackling a major risk factor for coronary heart disease, CHD, and what we call ASCVD, atherosclerotic cardiovascular disease.
Absolutely. And the fundamental principle, the main takeaway from years and years of research, is simple. Lowering LDL-C, that's the low-density lipoprotein cholesterol, the bad cholesterol, lowering that significantly cuts the risk of ASCVD events. That's the name of the game.
Okay, so before we jump into the drugs, let's quickly understand the system they're targeting. How do these lipids actually move around in our bloodstream?
Right. Well, lipids think cholesterol, triglycerides, or TGs. Phospholipids, they're hydrophobic, meaning they don't mix with water, which is most of our blood plasma. So they need transport. They get packaged into these tiny spheres called lipoproteins.
Okay.
These have a fatty core, the lipids, and then an outer shell that is water-friendly. And critically, this shell has proteins called apolipoproteins embedded in it. Think of them like address labels or ID tags.
Got it. So the apolipoproteins kind of direct where these packages go and how the body processes them?
Exactly. So the major players, you have chylomicrons, which mainly carry the fat we eat, dietary fat, then VLDLs, very low-density lipoproteins. They're made by the liver and carry triglycerides the body makes, endogenous TGs.
Okay.
As VLDLs circulate and drop off those TGs, they morph into IDLs, intermediate density lipoproteins, which don't last long. And then finally, they have LDLs, low density lipoproteins.
And LDL is the problem child here, containing what, 60–75% of the total cholesterol? How does having too much LDL actually lead to heart disease?
Yeah, that's where atherosclerosis comes in. It's a process. It starts when there's too much LDL floating around, and some of it seeps under the inner lining of the artery, the endothelium, into a space called the intima.
Okay.
Then, immune cells, monocytes, they get attracted, squeeze into that space, and transform it to macrophages. These macrophages basically start eating up the LDL, especially once it gets modified or oxidized.
And these LDL-stuffed macrophages become foam cells, right? That's the fatty streak stage we hear about. And the sources say this can start surprisingly early, like mid-teens.
That's right, often very early,
Yeah.
and it's completely silent. That fatty streak is just the beginning. Over time, with continued inflammation, smooth muscle cells move in, deposit matrix. It becomes a more complex, rigid, fibrous plaque.
And that's when things get serious because the plaque starts narrowing the artery.
Exactly. It starts to compromise blood flow. Clinically, this is where symptoms often appear. When the blockage hits around 50%, patients might feel angina, chest pain, especially with exertion. If it gets to 70% or more, they might even get angina at rest.
And the worst-case scenario is when that plaque breaks open.
Yes. That's the complicated lesion. The plaque ruptures, a clot forms right there, and that can cause an acute event, a heart attack, a stroke. That's the major danger we're trying to prevent.
Okay, that pathophysiology makes the need for risk assessment really clear. You mentioned modern guidelines, the 2018 ACC/HA ones shifted focus.
They did. Instead of just shooting for a specific LDL number for everyone, the focus is now much more on assessing the patient's absolute risk of having one of these events in the next 10 years.
So how do we estimate that risk, especially for someone who hasn't had an event yet, primary prevention?
For primary prevention patients, typically adults aged 40 to 79, we use the Pooled Cohort Equations, the PCE. It factors in age, sex, race, cholesterol levels, blood pressure, smoking, diabetes status, to give that 10-year ASCVD risk percentage.
And what about secondary prevention, people who've already had a heart attack or stroke?
Well, for them, the risk assessment is simpler in a way. They've already declared themselves as very high risk just by having that event, so they automatically qualify for high-intensity treatment, generally.
Makes sense. Now, what if the PCE score for a primary prevention patient is kind of borderline, say in that 5% to 7.4% range? The guidelines mention using risk-enhancing factors.
Yes, those are crucial for refining the decision when the risk isn't clear-cut. There's a list, but key examples include things like having chronic kidney disease or a strong family history of early heart disease, or maybe inflammatory markers like hsCRP being persistently high over 2 mg/L. These tilt the balance towards treatment.
And there's imaging too, right? The coronary artery calcium score, the CAC score.
Yeah, the CAC score, sometimes called the Agatston score, it's a fantastic tiebreaker, especially in that intermediate risk zone. It's a CT scan that looks for calcium buildup in the coronary arteries.
How does it help decide on statins?
Well, if the CAC score is 0, it means there's no detectable calcified plaque. That patient's 10-year risk is actually very low, even if the PCE suggested otherwise, and you might reasonably decide to defer starting a statin, maybe recheck in 5 or 10 years.
And if it's high?
If the score is, say, 100 or higher, or in the 75th percentile for their age and sex, that indicates significant plaque burden. It strongly correlates with a 10-year risk of 7.5% or more, pushing the decision firmly towards starting a statin.
Okay, quick question though. The source mentions CAC isn't useful if someone's already on a statin. Why is that? Does it mean we can't track plaque changes?
That's a great point. Once someone starts a statin, the drug works partly by stabilizing existing plaque, sometimes even increasing its calcium density, which might paradoxically increase the CAC score. So it loses its predictive value for future events after treatment starts. The focus then shifts to monitoring their LDL response and adherence, not rescanning CAC.
Ah, okay, that clarifies it perfectly. So let's nail down those 4 main groups, the statin benefit groups, where statin therapy is pretty much indicated.
All right, group 1. Anyone with clinical ASCVD, prior heart attack, stroke, peripheral artery disease, revascularization, highest risk.
Got it.
Group 2. People with severe hyperlipidemia, defined as an LDL-C level of 190 milligidil or higher.
Okay.
Group 3. Individuals aged 40 to 75 who have diabetes mellitus and an LDL-C between 70 and 189 milligidil.
Makes sense. And the last one.
Group 4. Those in primary prevention, aged 40 to 75, with an LDL-C between 70 and 189, and a calculated 10-year ASCVD risk of 7.5% or higher, possibly refined by those risk enhancers, or a CAC score.
So for all these groups, the first-line treatment is clearly a statin, the HMG-CoA reductase inhibitors. What exactly are they doing inside the liver cell?
It's quite elegant, actually. They block an enzyme called HMG-CoA reductase. This enzyme is crucial. It controls the rate-limiting step in the liver's production of cholesterol.
So you block the factory's main choke point.
Precisely. When the liver can't make as much cholesterol internally, it senses this low intracellular level and compensates. It puts out more LDL receptors, LDL-ARC, on its surface. These receptors grab LDL particles from the blood and pull them into the liver for processing.
So less production inside, more cleanup outside. That's why we talk about statin intensity based on how much LDL reduction we expect.
Exactly. We categorize them based on their typical LDL lowering power. High-intensity statins, like atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams, aim for a 50% or greater reduction in LDL-C.
And moderate?
Moderate intensity aims for a 30% to 49% reduction. It's important to remember these effects aren't instant. You need to wait about 4 to 6 weeks to see the maximum effect, so don't adjust doses too quickly.
Now, the big challenge with statins often comes down to side effects, particularly muscle symptoms, aches, pains, weakness. That seems to be the #1 reason people stop taking them.
It absolutely is a major barrier to adherence. We hear about myalgia, which is just muscle pain. Then there's myopathy, which is more specific, muscle symptoms, plus a significant elevation in creatine kinase, or CK, typically more than 10 times the upper limit of normal.
And the really serious one is rhabdomyolysis.
Yes, rhabdo involves massive muscle breakdown, CK levels sky high, potentially causing kidney damage. That's a medical emergency, and the statin must be stopped immediately. But it's also very rare.
The guidelines now say we only check liver enzymes, LFTs, and CK levels if the patient actually has symptoms suggesting liver toxicity or myopathy. How do you counsel patients about this, especially given the anxiety around muscle pain?
That's key. You have to explain that while muscle aches are common, true statin-induced myopathy is actually uncommon. We need to investigate their symptoms, rule out other causes like hypothyroidism or just overexertion before blaming the statin and stopping this crucial therapy. Careful discussion is vital.
Good point. And quick reminders, usually best taken in the evening or bedtime, since cholesterol synthesis peaks overnight, and absolutely contraindicated in pregnancy category X and in active liver disease.
Right. So what if someone needs more LDL lowering than a max tolerated statin provides, or they truly can't tolerate a statin? That's where the non-statin therapies come in, primarily as add-on treatment according to the 2018 guidelines.
Okay, first up is usually ezetimibe, brand name Zetia. How does that work differently?
Ezetimibe works in the gut. It specifically blocks cholesterol absorption at the brush border of the small intestine, so less dietary and biliary cholesterol gets taken up.
And the effect.
On its own, it lowers LDL maybe up to 18%, but the real benefit is adding it to a statin. You can get an additional 15% to 25% LDL reduction. And importantly, the IMPROVE trial showed that adding ezetimibe to simvastatin actually reduced cardiovascular events compared to simvastatin alone, which was a big deal, the first non-statin to show that incremental benefit.
Minimal side effects, too, mostly GI related, right?
Generally well tolerated, yeah. Maybe some headache or diarrhea? There is a slight increased risk of myopathy when combined with a statin, but much less than, say, doubling a statin dose often.
Okay, for patients needing even more firepower, maybe those with genetic conditions like familial hypercholesterolemia or very high-risk ASCVD patients still not at goal, we have the PCSK9 inhibitors, evolocumab.
Yes, these are monoclonal antibodies given by injection. They target a protein called PCSK9. Normally, PCSK9 binds to LDL receptors on the liver and causes them to be broken down.
So PCSK9 is like the receptor's enemy.
Sort of, yeah. By inhibiting PCSK9, these drugs prevent the degradation of LDL receptors. More receptors stay active on the liver surface, leading to really dramatic LDL clearance from the blood. We're talking reductions of 50%, 60%, even more, on top of statin therapy.
That's impressive. Downsides?
Well, they're injectable, which some patients dislike. Common side effects are usually mild, like cold symptoms or injection site reactions. The biggest hurdle, honestly, has been their cost and getting insurance approval. That often limits their real-world use despite the powerful effect.
A practical constraint. Okay, let's touch on some older classes. Bile acid resins, like cholestyramine or cholecalcivelum.
These work in the gut too, but differently. They bind to bile acids, preventing their reabsorption. The liver then needs to make new bile acids, and it uses cholesterol to do that. To get more cholesterol, it increases its LDL receptors.
So another way to boost LDL clearance? Any big cautions?
Yes, they can sometimes increase triglyceride levels, especially if baseline TGs are already high. And they cause a lot of GI side effects: constipation, bloating, gas. The major clinical pearl is drug interactions. Because they bind stuff, they have to be taken separately from many other meds, usually 1 hour before or 4 hours after, to avoid reducing the other drug's absorption, being thyroid meds, certain antibiotics.
Good tip. Next, niacin or nicotinic acid, famous for raising HDL, the good cholesterol.
It does raise HDL, sometimes up to 35%, and it lowers TGs and LDL too by decreasing VLDL production. But its place in therapy is really limited now. It causes significant flushing and itching in many people. The tip is taking aspirin 30 minutes before can help, but it's still bothersome.
And does it actually help outcomes?
That's the main issue. Large trials adding niacin to statin therapy failed to show any additional reduction in heart attacks or strokes, despite the HDL boost. Plus, it has contraindications like gout and active ulcers, so rarely used for LDL lowering anymore.
Okay. Lastly, the fibric acid derivatives or fibrates, gemfibrozil, fenofibrate.
Fibrates are primarily triglyceride-lowering drugs. They work mainly by activating PPAR-alpha, which stimulates lipoprotein lipase, an enzyme that breaks down VLDL particles. So think of them mainly when TGs are very high, say over 500 milli-GDL, to reduce pancreatitis risk.
Any major interactions, especially with statins?
Yes, this is critical. Combining fibrates, especially gemfibrozil, with statins significantly increases the risk of myopathy. In fact, gemfibrozil plus simvastatin is contraindicated. Fenofibrate seems a bit safer in combination, but caution is still needed.
Okay, that covers the main drug classes. Of course, we can't forget lifestyle modifications.
Absolutely essential. Diet-limiting saturated trans fats, focusing on patterns like DASH or Mediterranean, exercise, regular aerobic activity, aiming for maybe 40 minutes, 3-4 times a week. And smoking cessation is huge risk drops significantly within just a year or two of quitting. These are foundational.
Let's put this together with a case. Imagine JJ, he's 55, has type 2 diabetes, hypertension, a family history of early heart disease, and his initial LDL is 190 milli-GDL.
Okay, JJ clearly fits into multiple statin benefit groups. He has severe hyperlipidemia, LDL is $190, and he has diabetes within the age range. No question, he needs aggressive therapy.
So the initial plan?
High-intensity statin. Atorvastatin 40 or 80 milligrams, or rosustatin 20 or 40 milligrams. We'd counsel him, start the drug, and recheck lipids in maybe 1 to 3 months, looking for at least that 50% LDL reduction.
All right, but say JJ comes back in 6 weeks complaining of significant muscle aches that started after the statin. He's thinking of stopping it. What's the approach?
This is common. First, rule out other causes. Check a CK level maybe. If it seems likely related, we don't just give up. The goal is maximally tolerated statin therapy. We could try lowering the dose to a moderate intensity, maybe switch to a different statin known for fewer muscle issues, or try less frequent dosing like every other day.
And if even moderate intensity isn't tolerated?
Then we'd likely keep him on the highest dose he can tolerate, even if it's low intensity, and then add a non-statin, probably etiologically first, to try and reach an acceptable LDL goal given his high underlying risk. Abandoning statins completely is usually the last resort.
That makes sense, a stepwise approach. Now, a different scenario. WR, she's 79, has cognitive decline consistent with Alzheimer's, is frail after a recent fall, takes multiple medications. Her LDL is actually well controlled at 69 mg/dL on a moderate intensity statin plus ezetimibe.
This case brings up the important issue of deprescribing, especially in older adults. The evidence for starting statins for primary prevention in adults over 75 is less robust. WR already has limited life expectancy, frailty, and cognitive issues.
So the risks might outweigh the benefits now.
Potentially, yes. The long-term cardiovascular benefit of the statin, which accrues over many years, needs to be weighed against the immediate risks of polypharmacy, potential side effects contributing to falls or confusion, and the overall burden of treatment in the context of her quality of life.
So a conversation about potentially stopping the statin and/or ezetimibe would be very appropriate here.
Absolutely. It's a shared decision-making process with her and her caregivers, focusing on her current goals of care, safety, and comfort, rather than strictly adhering to a guideline designed for younger, healthier populations.
That really highlights the need for individualized care. Any quick notes on other special populations? Pediatrics, women?
Yes, for kids, statins are sometimes used, usually after age 10, for things like familial hypercholesterolemia, typically under specialist guidance. For women, the big thing is pregnancy statins are category X, absolutely contraindicated, need effective contraception if on a statin and planning pregnancy. And for geriatrics over 75, as we discussed, moderate intensity might be considered for primary prevention if otherwise healthy, but deprescribing is often a key consideration.
Okay, let's try to summarize the absolute core takeaways from this pharmacotherapy deep dive for managing hyperlipidemia.
All right, takeaway number 1, forget chasing one single LDL number for everyone. Modern treatment is all about ASCVD risk stratification. You categorize the patient first, then decide the necessary intensity of therapy.
Right. Second takeaway, statins are the foundation, period. You choose high or moderate intensity based on which of those 4 benefit groups the patient falls into.
And third, non-statins like ezetimibe and the PCSK9 inhibitors are really important, but primarily as add-on therapy. They come into play when the maximally tolerated statin dose isn't enough to reach the goal, or if true intolerance limits statin use.
Excellent summary. And maybe a final thought for you, the listener, to consider as you apply this. We have incredibly effective drugs and pretty clear guidelines now, but the real challenge often lies beyond the pharmacology itself.
Yeah, it's about patient adherence, navigating those tricky conversations about side effects, especially muscle pain, making complex decisions about combination therapy, and really weighing risks and benefits in unique situations, like WR's case with advanced age and frailty. Mastering that application is key.
That ability to integrate the evidence with the individual patient's context, that's advanced practice. You've navigated a complex but critical area of pharmacotherapeutics today. Thanks for joining us for this deep dive.